The virtual ICU is basically a collaborative team with clinicians here in Sydney Local Health District and our wonderful clinicians in the Far West and Broken Hill ICU.
It's a telehealth service that connects intensivists at RPA to us here at Broken Hill.
There's 3 types of calls that we have in virtual ICU. There's a category A, B and C. Category A is a patient who is extremely unwell. It's a life-threatening problem. B is someone who is really unwell, and C is someone who's not unwell, but we're following up on a call, there's a question, there's some education.
We need to get a third-party opinion to consider whether or not this is an appropriate section or an escalation to a neurologist.
We have to confront the reality that in a remote setting, it's just not possible to have tertiary level physical care. And that's as true in Broken Hill as it is in other parts of the state, the country and indeed the world. Notwithstanding that lack of ability to have the full physical infrastructure, a very large part of the care that we need to provide can be provided via this virtual means. When there are people in the community who become seriously unwell, and sadly that is something that does happen regularly, they do have that very early, almost instantaneous access to that level of knowledge and care.
One of the journeys that we went on in establishing the virtual ICU with Far Western and Kayla and her colleagues was to understand how things were working currently at Broken Hill and how we could augment and complement all the great things that were actually happening. And so understanding those things was a great opportunity to learn how the systems were put together, and most importantly how, from an RPA perspective, we could then go in and not disrupt, I suppose streamline things as best we could when we're involved in those care moments.
You guys have escalated locally, Kayla?
We have escalated through all the escalation channels and now seeking a vICU Category C consult.
When we think about the traditional context of a remote or regional hospital seeking advice, it's usually by telephone to a tertiary centre, to somebody who is knowledgeable but doesn't have an understanding of the context, what our situation is, what our limitations are, and that can be our workforce, our equipment, our access to aeromedical retrieval. So the virtual ICU service was the result of quite a lot of work to understand the specific needs that we have in this specific location.
One of the things that we wanted to be was available and contactable and then supportive. We're a 24/7 service. We've got our most experienced intensive care nurses that are already used to providing outreach care, not only within the ICU, but also to the whole of the hospital at RPA. And there's an intensive care specialist rostered on 24/7.
We're very reliant on Adelaide for a lot of our more complex care, but the expertise at the Sydney LHDN can help with the decision making for our team about when they need to send a patient to Adelaide as opposed to keep them and manage them here. And so that's a really important decision point for us, and it's a really important decision point for the patient and their family.
The benefit for the patients is enabled them to be involved directly in their care with an intensive care team from a tertiary facility. Instead of the doctors and nurses talking to their team on the phone at the nurses station, the patient is involved in the care on camera and they can ask questions, their family can ask questions. So our goal here is patient-centred care for our patients and their families. It's just enabled that to happen.
We've got a history of quite junior nurses. We take on a lot of new graduates each year. And so it does give them, again, senior, experienced professional people on the end of the line that they can call for advice, assistance. And we've rolled that out across the district. And it does give some of our more junior staff, particularly our remote sites, the sense that they've got someone there if they need them. And we've had really strong feedback from our team that it's really helpful. So it's been a real success.
In ICU, you need clinicians at the bedside to provide hands-on care. We can never replace that. What we can do is support colleagues in remote and isolated places in the care that they provide.
We've had a lot of interest both nationally and internationally in this model of care, and perhaps what we can do over the next year or so is to continue to spread the message about how we've built what we've built so that others can take what they see as helpful to their health services from that model of care and from the learnings that we've had over the last year.
It's the relationship through the screen, it's the people that make this model of care work. And so far I think we're on a winning ticket, so it seems to be good.